This program, while curated to help you improve your health, contains general advice and should not replace the individual advice of your medical practitioner.
In the U.S., up to 1 out of 5 women is suffering from PCOS.
Anything that doesn't feel good is indicative of some type of imbalance.
So most women, if they have a body fat percentage less than 20%, will not ovulate and won't get a period.
Women with PCOS have the whole array of metabolic dysfunction.
I think people are more aware about the importance of nutrition.
PCOS, despite the name polycystic ovary, is nothing to do with cysts on the ovaries.
In life, it's normal to have ups and downs. But what do we do when we get stuck? I've always been fascinated by the healing journey. Why do some people get better while others fail to make the shift? In Season 2 of The Shift, we explore the intricate world of women's health and help you discover how to balance your hormones and understand yourself better so that you can truly thrive.
The menstrual cycle is a vital sign of female well-being.
My mum just used to say, "Oh, Nan, I'm so sorry. It's part of being a woman."
I would like a call to arms for women to know that their intuition isn't lying to them.
I'm Katherine Maslen, and this is The Shift. In this episode of The Shift, we will begin to look at what can go wrong when our hormones and related systems go out of whack. In episode 3, we looked at what happens during a healthy menstrual cycle. I'd encourage you to go back and take a listen if you haven't already, as knowing what's normal can help you to understand when things go wrong. But before we get stuck in, I'd love to ask you, how are you enjoying the series so far? This is a massive project for myself and my team. And if you'd like to say thank you, the very best thing you can do is to rate and review the show. If you need instructions on how to do this, go to theshiftclinic.com/review and we can show you how. Thank you in advance. As I mentioned in episode 3, your hormonal system is like a symphony orchestra with all parts contributing to the whole. One of the things that go wrong when it comes to issues with our cycles is the perception that you must have a particular hormone that is too high or too low, and that this is what is driving the issue. This is a very simplified view and doesn't really respect the fact that every hormone is connected to the next, and that many issues actually originate outside of our reproductive hormonal system. A good example of this is irregular cycles, which can have origins in places like your thyroid, adrenal glands, or metabolism. We spoke about what a normal cycle looks like in episode 3, so let's now try to understand what it looks like when things go out of balance.
Anything that doesn't feel good is indicative of some type of imbalance. You shouldn't feel anything other than maybe a little bit more tired, maybe a little bit more hungry, maybe a little bit heavy. So anything outside of that, whether it's pain, whether it's mood swings, whether it's heavy bleeding, whether it's very scanty bleeding, skin changes, digestive changes, anything that's not actually, I can't get up and do my normal thing without thinking about it sort of stuff, is definitely going to show signs of hormone imbalance. And you don't just experience hormone imbalance symptoms at the period time, you might see them also at ovulation time. That's fairly common, ovulation pain being a big one. Some women feel nauseous at that time as well, and they can feel moody at that time too. Tender breast is another thing that we can often see throughout that luteal phase that can indicate hormone imbalance. Headaches, they're the most common, I guess, things that we tend to see. And missing periods or a delayed period, that can be a sign of, obviously, of hormone imbalance as well. So it's important to understand that those things are definitely related to your hormones.
That was Nat Kringoudis, Doctor of Chinese Medicine. You've been hearing from her a lot as we've moved through the series. She's a specialist in female hormones and knows a thing or two about this area. The first thing I want you to ask yourself is, am I experiencing symptoms that only occur at certain times of my cycle? The most common are the 2 to 3 days around ovulation, the week preceding your period, and during menstruation. If things crop up in these times, it's likely that hormones are at play, at least in part.
The easiest way to work out if something's hormonal is ask yourself, is this cyclic? Does this come around every 2 weeks or every 4 weeks? Then you can generally say, yes, okay, this is hormonal. Whereas if you have acne 24/7, 7 days a week, then there's a chance that it's not just hormonal, that there's other things that are at play. Yes, there's a hormonal element to it, but there's probably other things that you need to look at. That's probably the best clue I can give people to look at. Is it cyclic or is it just a daily occurrence?
Menstrual pain is never normal, but it's pretty common to have a bit of cramping on the first day or two of the bleeding. And by a bit of cramping, I mean the kind of discomfort that you can take one Nurofen and it goes away. It's okay. That's the sort of level of pain. And you can still go about your day.
That was naturopath Dr. Lara Bryden. We're going to delve into period pain more in the next episode. But for now, you can be sure that period pain is a sign from your body telling you that something is out of balance and needs to be investigated. Most of us have experienced some level of PMS in our lifetime, and it is estimated that at least 20 to 40% of women experience moderate to severe premenstrual symptoms. PMS stands for premenstrual syndrome and can include a collection of symptoms that range from mild to debilitating. It's actually quite normal for us to feel a little different in the various stages of our menstrual cycle, because as we discussed in episode 3, the hormones involved in your cycle do cause subtle changes in how we feel and operate. If we're in tune with our bodies, we can use these differences to change our routines to suit what's going on. If you haven't listened, make sure you go back to episode 3 and learn about this because it is so fascinating. What is not normal is any symptoms that cause us discomfort or pain. Here's a list of symptoms that are not normal, but are dealt with by many women month to month because they think that there isn't anything that they can do about it. Moodiness, including feeling more anxious, more depressed, irritable, snappy, or more on edge than usual. Significant changes in weight and body shape. Feeling bloated and retaining fluid. Your pants might not fit as well, or your rings may be tighter on your fingers, for example. Headaches and migraines. Sore breasts. While a little discomfort can be normal, painful or swollen breasts are not. Constipation, diarrhea, or any gut pain related to your cycle. Extreme fatigue or foggy-headedness. Acne or breakouts on your skin. Sugar or chocolate cravings. And as we mentioned, any period pain beyond a dull ache is not normal. My guess is that if you're listening, you've experienced or are currently experiencing some of the things on this list. What is very important to understand is that these signs and symptoms are your body's way of showing us that something is out of balance. What you'll notice as you begin to heal by eating the right foods for you, decreasing stress, or getting treatment to help with this is that these symptoms begin to reduce and fade away. It's also important to note that some of these symptoms might occur at mid-cycle, or perhaps when you have your period. If hormones have a role, then they will be cyclical, recurring in certain stages of the month. If you need to get more familiar with your menstrual cycle, once again, go back to episode 3. We're going to talk more about endometriosis in episode 7, where pain can be more difficult to treat. But when it comes to most PMS symptoms, there is so much you can do to help them. The first step is to do some investigations. It's very important that you work with someone that understands hormonal health, as in addition to testing your hormones, we want to take a look at your thyroid, adrenal health, and general nutrition to get the full picture of what is going on. When our naturopaths are assessing our patients' hormones at shift, we first look at what testing you have had done and then organise testing to fill the gaps, which may include things like blood tests or urinary hormonal panels. But what is also important is that you track your cycle and symptoms so that we can see what your body is trying to tell us and use that information to decide what you need to do. You can download our Shift cycle tracking guide for free at theshiftclinic.com/links. The causes of PMS can be many. Some of the most common causes include imbalances in your estrogen and progesterone, excessive stress, and poor diet. Namely, a diet with too much sugar and refined carbohydrates is often to blame. Many people will find that by cleaning up their diet and reducing stress, their PMS symptoms will improve somewhat. But for others, hormone balancing treatment will be required. One of the things that we're seeing more and more of at Shift is PMDD, which stands for premenstrual dysphoric disorder. This is a heightened form of PMS where the patient can report issues like severe anxiety, irritability, and depression. With PMDD, the symptoms are so severe that women can have trouble functioning at work, home, and in their relationships. They can often feel like such a different person that when their period arrives and the symptoms lift, they can feel remorseful about their behaviours or actions during this time. I asked Nat Kringudis what she had to say about it and why it occurs.
I think it's probably more of a genetic predisposition. And anything that you're experiencing in terms of signs and symptoms, I think, again, that's also important to weigh in. Your genetics dictate what you're dealt. It's not that that's the deciding factor, however. It's the environment that we put ourselves in that turns on and off those various traits. We're like human petri dishes. You've done that experiment where you put one in an incubator and one on a windowsill, and different things have grown. Even it's just the environment that's changed what's grown. And so we're a little bit similar to that. And I think in these instances, for something like PMDD, if enough of these stresses, if enough of them are turned on, coupled with the right match of genes, that's just going to be what presents for you. And I guess the further down the line you go, the more it goes from being PMS slipping into PMDD. I think one's often an extension of the next, and it's simply just a bigger imbalance that you're experiencing more than anything. These things are really treatable, and I think that's the other issue, is that we get a diagnosis and we feel like, oh, well, now at least I know what's wrong, and often that's where the buck stops, and that's not the case. That diagnosis hasn't actually changed anything in terms of what you're experiencing and how you feel. It's just given it a label. So I think being able to detach from the label and just looking at you as an individual and using your symptoms as clues as to how you can then best be treating what's going on, that has the biggest impact, not the diagnosis itself. But I mean, I'm sure you'd see the same thing. We love a diagnosis. We love a label. We love to be able to say, oh, I have this or I have that. And we all probably have a variation of each of everything. PMDD, I think it's so debilitating, and often it can be hard to have that perspective that there is actually ways to treat it and options. And it's definitely a combination of lifestyle, nutrition, but the same as everything. It's just about working out what's the actual imbalance. And it's so often low progesterone, so often for women, low progesterone. And that's, again, a really big symptom of elevated cortisol, which is your stress hormone.
Genetics certainly play a role in the development of these women's health issues, but as Nat touched on, there is so much more at play. I asked integrative gynaecologist Dr. Felice Gersh why she thought we were seeing such an epidemic increase in women's health issues.
Well, it's the perfect storm. It starts in utero. So we now have data predominantly on BPA, bisphenol A. So BPA comes in a variety of sources. It's from a petroleum product. It's found in different kinds of plastics. So every single person, because of all the plastic in our lives, every single person has BPA in their body, or close to 100%. The problem is in utero, they said, oh, but the levels in the woman, the pregnant woman, they're really low. Well, it turns out that they were measuring it incorrectly. There's new articles that showed that the scale and the whole technique that they were using to measure it was wrong. But even with that, what they also found is that it concentrates in the fetus. So BPA is a known xenoestrogen. It works on the estrogen receptors, but it's not estrogen, it's plastic. And in utero, remember I mentioned that you only get one chance to make your receptor system for your hormones. It's in utero during the fetal time. So if you have BPA in the mix, what happens is the receptors are not made properly. So this has now been shown in studies that women with PCOS have abnormal receptor function, reduced receptor function for both the estrogen receptor alpha and beta. Those are the two main predominantly nuclear receptors. Both of them are lowered receptivity. So remember I mentioned that a receptor is like a mouth. It can be open, or it could be partially open, or it could be closed. So in women with PCOS, their estrogen receptors are more closed than open. So this is like a double whammy. They make less estrogen, and the estrogen receptors are less open. They're less receptive. So women with PCOS are actually living a life of estrogen deficiency. They now have shown that you can identify kids that are like 7 years old who have a high chance of developing PCOS by measuring a certain hormone called adiponectin. This is a hormone made by the adipose tissue, which is the fat tissue. So fat, it turns out, is an endocrine organ. I didn't mention that before. So fat makes all kinds of hormones like leptin and adiponectin, makes others as well. So it's very metabolically active and it's hormonally active tissue. So it turns out that adiponectin is a hormone made by fat tissue that promotes fat burning. So you can find low levels, because you want high levels help you to burn fat, and they find abnormally low levels of adiponectin in the blood of girls at age 7 who are prone to developing PCOS. They've also shown that girls who develop PCOS when they're children tend to they never get rid of their baby fat. They have like little pudgy bellies. They just, even though they eat no differently than their friends, they just carry more body fat, even at a young age. So that's like the beginning. Then you add to that the problems with the food, the chemicals in the food, the lack of nutrients like magnesium, which is so key to glucose transport and proper function of glucose and so on in the body. So we have all of these deficiencies. Now, even in children, they make estrogen, but they don't make it from ovaries because they're children. Even the girl children, they make it in organs. So it's called paracrine. So different organs in the body, many organs in the body can make estrogen on their own, like the brain, the gut makes estrogen, for example. But the problem is, even if they could make it well, what are they going to do if the receptors aren't working properly? So little girls are already at a disadvantage in childhood. And then what typically happens is when they go through puberty, because of the abnormal ovarian function, they have like an explosion of testosterone and abnormal cycles. And because of the high levels of cortisol that happen at puberty, they start putting on a ton of weight. And then that just increases inflammation. And like we talked about, it's all downhill from there. So it's poor choices, chemicals in food and water. And then you add on that circadian rhythm dysfunction. So all of these things come into play, and you can see how there's an explosion of PCOS in the world.
If you're curious about your hormonal health, take our quiz. You'll get a report with insights into some key areas you need to look at when it comes to getting your hormones in alignment, as well as some handy tips to get you started. Go to theshiftclinic.com/links. There is no denying that the diagnosis of PCOS is on the rise. It's in one of the top 5 conditions that we treat at the Shift Clinic. I wanted to ask Dr. Felice Gersh what the data showed.
Well, we now know that many women with PCOS are never even diagnosed until they're seeing like the 7th to 11th doctor, because they just don't see the picture of the woman. It's getting to be a little bit more common because it's gotten a little bit more notice, but traditionally, we're talking about up until like about a year ago, there have been articles published on it that women often are not diagnosed with PCOS for many, many years. So obviously they're going sometimes to doctors, but instead of putting PCOS as their label, their diagnosis, they may be putting down irregular cycles or acne or prediabetes or some other symptom that they're experiencing rather than the label PCOS. But even so, the estimates are in the US up to 1 out of 5 women, maybe even as much as 1 out of 4 women now is suffering from PCOS. If you look at older data, they say 5%. So instead of 5%, we're 20%. I'd call that a pretty big jump. In India, where I just was, some are estimating, and they hide this because they don't want to be known as a PCOS woman if they can avoid it, especially before they get married. But some people think it's over 35%, as high as 39% of women in India are now suffering from PCOS. And in China, I was there in October, a few months ago, and that's a big problem there. I was actually seeing some of the women with PCOS while I was there, and I put on a big half-day program on PCOS, and it was completely filled the room because of so many women dealing with PCOS.
PCOS stands for Polycystic Ovarian Syndrome, and it's a really interesting diagnosis. The reason for this is that often women do not have polycystic ovaries, as the name suggests. PCOS is a pretty new condition, I guess, in the medical world, and many practitioners misunderstand what it is and how to manage it. Misdiagnosis is common, with patients with irregular or absent periods for other reasons being given a diagnosis of PCOS by a well-meaning doctor, who perhaps doesn't understand the criteria or how to look for other causes of menstrual disturbances. This is where it's important to treat what is going on for you, not just your condition. As a medical herbalist, I can tell you that there is no one PCOS herb that will cure you. There are, however, many wonderful herbs that can work on the individual factors that might occur for your particular PCOS. We may prescribe herbs to decrease testosterone, increase or decrease estrogen, decrease luteinizing hormone, or reduce sex hormone binding globulin. What I'm trying to say here is that the success of treatment depends on knowing all of the information and seeing someone that can help you work on the parts that matter for you. With this type of individualised care, our clinic has helped thousands of women with PCOS to get back into balance, ovulate regularly, and even go on to have a healthy conception and birth. There really is a lot of high-level information here, and I'm sure already you may be learning something that you didn't know before. Let's see what Dr. Lara Bryden has to say about irregular periods and the diagnosis of PCOS.
So after the doctor has ruled out all possible reasons for losing a period, such as thyroid, prolactin, gluten, then often at the end of the day, irregular periods or lack of periods comes down to either PCOS or hypothalamic amenorrhea, also known as undereating. Those are the two most common explanations for irregular periods or no periods in younger women. There's also the possibility of menopause or early menopause, which the doctor can easily rule out with a blood test. If that's been ruled out, then we're left with the two most common, PCOS or hypothalamic amenorrhea. Now, I mention those two together because they have a few similarities, which means that they're sometimes misdiagnosed, one for the other. And also they have enough differences that the treatment is completely opposite. The PCOS is, despite the name polycystic ovary, is nothing to do with cysts on the ovaries, like absolutely zero to do with cysts on the ovaries. It's actually the situation of a miscalibration between the brain, the pituitary, and the hypothalamus and the ovaries. So the communication is happening in a way that ovulation is not occurring regularly, and there's an overproduction of androgens or male hormones. That's the crux of PCOS. That's the center of it. It's about high male hormones and usually irregular ovulation resulting in irregular bleeds and ovulatory cycles or no cycles at all. The so-called cysts that are being referred to in the polycystic ovary finding are really just follicles or eggs, which are normal for the ovary and will change every month. So you could have quite a number of follicles, one cycle, but then they'll be reabsorbed and new ones made. So your ovaries could look totally different. That's why I really, with my own patients and in my writing, try to direct people's attention away from that ultrasound finding because it's very confusing because it doesn't diagnose the condition of polycystic ovary syndrome. And likewise, the ultrasound finding of polycystic ovaries is so common that it can occur with anyone, including with women who have hypothalamic amenorrhea or undereating, which is why a very common situation currently is for young women with undereating, also called hypothalamic amenorrhea, to be misdiagnosed as having PCOS because they have polycystic ovaries on ultrasound. Both conditions can present with irregular cycles or no cycles. Both can present with polycystic ovaries on ultrasound. The difference is that PCOS usually has much stronger symptoms of androgens or male hormones such as facial hair or jawline, acne or breakouts, whereas hypothalamic amenorrhea can have a small amount of breakouts or facial hair, but not significant. And then From that point, they'd start to look very different because PCOS is either associated with normal body weight or overweight, or normal insulin or insulin resistance, whereas hypothalamic amenorrhea is associated with undereating, low fasting insulin on a blood test. The treatment for the two conditions is very different in that PCOS often may have to do some degree of altering the diet to perhaps avoid high sugary desserts to reverse insulin resistance, whereas hypothalamic amenorrhea, the main treatment is to eat way, way more to recover from hypothalamic amenorrhea and get your period back, and that can take 6 months.
What Dr. Lara talks about here really is food for thought, as an ultrasound has long been the gold standard when it came to diagnosing PCOS. This isn't to say that an ultrasound is a bad idea, as it will help you check things out. However, it might not be relevant when it comes to your particular PCOS. To get a proper diagnosis, hormonal panels are actually more important so that you can see the underlying reasons why your periods might be absent or irregular. Let's talk a little bit more about amenorrhea, or losing your period altogether. This is a serious concern, especially if having a baby is something you're looking to do in the near future. There are 2 types of amenorrhea, primary and secondary. Primary means you've never had a period, and secondary means that you've gotten your period but it's stopped coming. I asked Dr. Lara to talk about these issues more.
So primary amenorrhea is the situation of never having had a menstrual cycle. That always needs to be under the care of an endocrinologist to look at what's going on. I mean, there can be some congenital things, there can be high prolactin. That's sort of beyond the scope of normal natural period repair. I guess one slightly more common situation of, never having had a natural menstrual cycle, if everything else is working well and the endocrinologist has ruled out more obscure possibilities, there can be the situation where a young woman is just undereating at that age when she was supposed to be getting her menstrual cycles, and so gets it a lot later or doesn't get it until she eventually starts eating enough. But definitely primary amenorrhea, or having never had a menstrual cycle, is a more serious situation than secondary amenorrhea, which is having had a menstrual cycle but then losing it.
Have you said hello on Instagram? It's where we post details of upcoming events, health challenges and other useful info. You can follow me at Katherine Maslen, that's KatherineMaslen, or at The Shift Clinic. When I question my patients about their history, one of the things I'm wanting to know is how old they were when they got their period and what happened next. When I've had a client that's been doing lots of exercise or sports in their teenage years, or they've had a history of an eating disorder that's led them to have low body weight, they usually report not having gotten their period until much later on, or as Dr. Bryden described above, potentially not at all. Your sex hormones are manufactured from fat, so when your body fat percentage is too low, it will interfere with hormonal production. This is common for teenagers, but can also reoccur later in life when you decide to undertake an intense exercise routine or restrict your calories too much.
I actually saw someone I can think about just off the top of my head who had actually seen another gynecologist and then seen a naturopath. And the gynecologist had said, yes, you've got PCOS based upon her ultrasound and her absence of periods. This woman was doing like figure competitions. She had a body fat percentage of like 12%, which is low. So most women, if they have a body fat percentage less than 20%, will not ovulate and won't get a period. And she was undereating. She has hypothalamic amenorrhea, which is different to the typical PCOS. So I think the thing is, if you're diagnosed with PCOS, the number one question you should ask whoever made that diagnosis is, okay, what's the cause of my PCOS? Because there are multiple causes and you need to dig deeper around that.
That was Dr. Peter Wright, gynecologist and fertility specialist. How do we get our bodies into rhythm then? In episode 3, we spoke about the benefits from having regular healthy menstrual cycles. But how do we get there? The answer for this is going to be different for each and every one of you, but there's definitely some general advice that applies to everyone.
So it's really looking at getting a woman's rhythms in place. We now understand, and this is a really new understanding of PCOS, women with PCOS have the whole array of metabolic dysfunctions. They tend towards having inflammation because now it's been shown, the first study came out of China that showed that women with PCOS have gut dysbiosis. They have abnormal microbiomes of their gut, and that leads to leaky gut. And once you have leaky gut, you end up getting the immune system sort of activated and you get release of inflammatory cytokines. This was shown in 1998 by a researcher out of Indiana University that women with PCOS have immune cells that have a lower threshold to release inflammatory particles, what we call inflammatory cytokines. Now, in 1998, they had no idea why that was. It was just a finding. Now we understand all immune cells contain estrogen receptors. In the absence of estrogen, the immune cells are not well controlled, and they're more likely to respond to an inflammatory stimulus like the endotoxins that come through the gut wall when you have leaky gut. And these endotoxins, also known as lipopolysaccharides, trigger the release of inflammation particles, inflammatory cytokines from immune cells like mast cells. Well, the immune cells in women with PCOS, because they don't have enough estrogen, have a lower threshold. So they're more prone to releasing their inflammatory contents, creating an explosion of inflammation. So you have the perfect setup for problems. You have gut dysbiosis, leaky gut, immune cells that are like trigger happy and release their inflammatory contents. And then this inflammatory process, what does it do? It increases insulin resistance. Insulin resistance promotes more testosterone production. And then the testosterone goes down the assembly line into the granulosa cells, where through the enzyme, it's called aromatase, gets converted into estradiol. Well, in order for the enzyme aromatase to work properly, you need to have proper amounts of FSH, follicle stimulating hormone. It's now been shown that women with PCOS do not make enough FSH. Their enzyme aromatase isn't working properly. So they have like a block in their assembly line. They have plenty of testosterone, but they can't convert it properly to estradiol. So the brain says, hey, I want more estradiol. So it puts out more LH, luteinizing hormone, which triggers the production of testosterone. So you have more and more testosterone being produced, but you don't turn it into estradiol properly. So you have this excessive amount of testosterone, a deficiency of estradiol, and then when you have this inflammation in the high levels of insulin, that triggers the production of IGF-1, insulin like growth factor 1, which triggers the ovaries to make even more testosterone. So, this is like terrible. So you have all this inflammation, all this testosterone, and then you get all of the manifestations of hyperandrogenism, where a woman with PCOS gets facial hair and loss of hair and cystic acne, which is so challenging to treat. It's recalcitrant to all the standard treatments. That's what they call it, hormonal acne. And all this inflammation and creates more visceral obesity. And estrogen is involved in mitochondrial function. Those are the little structures in the cells that burn fat. So women with PCOS are very good at making fat, but they're very poor at burning fat. So they tend to accumulate fat. Even thin women with PCOS, which make up the minority, like 20% or less, if you did actually a CAT scan on them, they've done this in studies, even what they call lean women with PCOS tend to have more visceral fat or belly fat compared to other women at the same weight. So all of this needs to be controlled. Estrogen also regulates the master clock in the brain. It turns out that there's some data that women with PCOS live with the equivalent of a life of jet lag. So there's a lot of data on jet lag. Women who work the night shift, for example, like nurses in a hospital, they have much higher rates of obesity, depression, sleep problems, diabetes, and so forth. So the same problems that women with PCOS are dealing with. Women with PCOS have an upregulated sympathetic nervous system. They tend to be more producers of cortisol. They have a lower stress response. Just like they're more prone to a lower threshold of inflammation triggering, they're also at a lower threshold for stress stimulating. So it takes less to produce more cortisol for them. And cortisol then in turn creates more inflammation long-term, more gut leakiness, and more insulin resistance. So you can see it's everything snowballs together. So all of these facets are approached. And I have used this with my own patient population for quite some time with really dramatic results. For some women, I say, it may take a year to really get where you want to be altogether, but In most of my patients, after about 6 months, they're already cycling again. Almost all of my patients will cycle, not 100%, but most of them.
Now, I know there was a lot of information there, but the simple version is this. One thing leads to another in the body. Your hormones are interconnected, so when one has an imbalance, it impacts things down the line. You can have women with PCOS who have low estrogen, but there can also be instances where estrogen may be high. You can have women with PCOS that display androgenic symptoms like hair growth or acne, and others that do not. You can have women with PCOS that put on lots of weight, and others where you can't see any excess fat, at least on the outside, as Dr. Felice discussed. This can be applied to any health condition, really. What are the parts that are important for you? The conventional medical model is simply not set up to help women heal their hormonal issues. As we discussed in episode 4, using things like birth control may help to mask the symptoms, but it doesn't really get to the core of the issue and isn't much help if you're wanting to start a family either. Rachel is a Shift member, and you might remember her from the previous episode. I wanted to share some more of her story here so you can see how patients navigate the diagnosis of things like PMS.
I got my period when I was 13 or 14, and as soon as I got my period, it was just horrific, just extremely painful. Every time it came, it was very irregular, and I would get really nauseous. Sometimes I would actually vomit from the pain. And I guess at the time, looking back now, I know that that wasn't normal, but it wasn't really talked about that much. I'd never heard of polycystic ovarian syndrome. I'd never heard of endometriosis. And so when I was 15, I went to a doctor, and without sort of asking anything about family history or doing any tests, that he just said, go on the pill. So he put me on Yaz, and I was on that for quite a few years, and that did regulate my period. The pain sort of went away. And then I went off it when I was 22, and I just thought I just didn't want to be on it anymore. And as soon as I went off it, a few months into it, I was getting those symptoms again. Really heavy periods, really bad pain. They were very irregular. I was getting, I got male patterned hair growth. My moods were sort of all over the place. So I went to a doctor, and I looked up a doctor that specialized in women's health this time, because I thought I always knew there was something wasn't wrong, that I probably needed some other tests. So I went to her, and she diagnosed me. So I got an internal ultrasound and had blood tests, and she said, you've got polycystic ovarian syndrome. And she basically said, you need to go on the pill. That's the only way you'll get your period. And she said, you probably won't be able to have children naturally. And when you want to have children, come and see me a few years before, and we'll look into IVF. It was a lot to take in. And so I just went on the pill. That's what I thought I had to do. It was extremely confronting and made me feel very hopeless, and like my body, was failing me, because there was no really other explanation. There was no exploring into my lifestyle, like my diet, anything like that. It was basically just, you need to go on the pill. This is what's wrong with you. This is what's going to happen. And there was nothing else. So I did that at the start. I went on the pill, and then I just decided to do my own research. I started listening to podcasts and coming across things, and I found women with a similar story to me, and that exactly the same thing happened. They had those symptoms. They went to their GP, they got put on the pill, they were told the same thing, and they had gone and done their own research as well. And then I found that it wasn't the only way. You don't just have to go on the pill, and that there was a lot of negative things about being on the pill and negative effects that you can come across later in life that can make your fertility even worse. And looking at what diet you're having, your lifestyle, exercise, all that, those sort of factors. So, and then I decided to look into naturopathy.
So what did the journey look like for you? When you walked into that naturopath's office, do you remember all of the symptoms that you had, all the different things that you had going on for you?
I was still on the pill when I came, but I wanted to get off it. So Nicole really worked with me on preparing my body to come off of it. So she looked at just getting my body ready, getting on supplements and stuff like that, and really, I guess, just healing, detoxing of all the hormones that were in my body, changing my diet. So dairy, I learned, is really inflammatory to PCOS, which I had no idea about. And, I had really poor energy levels and things like that. having regular exercise, all that sort of thing. So it was really focusing on, like diet and lifestyle changes to get myself off the pill. And so then when I would get those symptoms to like help manage that. And I was seeing Nicole quite frequently at the beginning. And just to have someone check in on me, how am I sleeping? How's my mental health? How's my mood? How's my diet going? Which is something that in Western medicine, when you see a GP, I'd never been asked those questions before, just to look completely holistically, which was very new and really great.
I have to say, hearing stories like this really get to me. Words can be very powerful, and having a doctor tell you that you will probably have issues having kids when you're just 22 years old is not only confronting for the patient, but can also plant a seed that can cause negative consequences further down the track. My approach would be to help the patient understand the mechanism of what is going on for them and to empower them to work on their issues long before they want to start a family, rather than make an assumption that they will be infertile. We do see many, many patients with infertility at Shift, but we really want to be improving your fertility far before you want to get pregnant, as having good fertility and regular cycles is actually a sign of health. Dr. Suzanne Bartlett is a gynaecologist and forest therapist. She's been working with patients holistically for a long time, so I wanted to hear what she had to say.
I believe in trying to get to the root of the problem and looking at the whole patient, everything from their diet and their exercise and their micronutrients and stress and mind-body practices and all of those kinds of things. That's not the norm, though, in this country, and especially where I live. More often, a patient would be given a medication option, a hormonal option, birth control pills, things like that. And then, of course, surgery would be the last resort for things like endometriosis or PCOS. Unfortunately, most conventional OB/GYN doctors in this country still are only armed with pharmaceutical medications in their toolbox, and especially here in the Midwest. Certainly, there are more options on both coasts of the United States where there is more open-mindedness towards integrative treatments. I think people are more aware on both of the coasts of the U.S. about the importance of nutrition and the importance of avoiding environmental toxins and things. But that's definitely much more of an uphill battle where I currently live.
What I want to leave you with from this episode is the fact that there's actually so much information out there about why you're experiencing what you're experiencing. The emerging research on hormones is phenomenal, and more we can understand the intricacies of this part of your body and why things go wrong. And we're going to talk about this more as we move through the series. Help is available, and by seeing someone that has the education and knowledge to look at your whole unique picture, you can begin your journey to healing. There are too many hormone-related issues to cover in depth in this episode, but one that we want to explore more is period pain. As mentioned, pain is not normal, so in the next episode we're going to explore what it means and what you need to do to shift things.
Coming up on The Shift.
I see so many women with pelvic pain.
It's interesting that over time we've developed this concept that period pain is normal.
They feel like their bodies are broken and that need to be fixed by someone.
Your vagina and your orgasms are a barometer.
So I've been going down this rabbit hole of research of how our hormonal system can actually dictate our pain responses.
What do I need to feel more peaceful, to feel more loving, to feel more safe?
This series is a production of The Shift Clinic. Hosted by Katherine Maslen. Music and sound design by Shade Furlong. Thank you to all of our experts. For more details on them, go to theshiftclinic.com.
We can be. We must be.
The first generation to end extreme poverty.
The generation most determined to fight injustice
and inequality. the generation that saves the planet
from climate change.
And this is how we will get it done.
The Global Goals.
A 15-year plan for everyone, everywhere.
With no one left behind.
The Global Goals are a framework that collectively help us
support the health of our people
and the planet.
At Shift,
we are ambassadors for the Global Goals.
This project supports Global Goal number 6.
Clean water and sanitation.
Every time you listen
to an episode of The Shift,
we provide a day's access to clean water
for a human in need
in Malawi, Africa.
Water is the foundation to health, and we believe
every human should have access
to clean, healthy water.
So please share this podcast wide
and keep tuning in
so we can impact those who need it the most.